My name is Marie McGrath, and together with my MAMI colleague Carlos, I'm going to share with you some of the headlines coming from 10 years of effort on MAMI. What is MAMI, or Management of At-Risk Mothers and Infants under 6 months? Why is it important? Where we are heading? How we are building critical evidence in Ethiopia? And why nutrition leadership from Ethiopia is critical to helping us achieve our vision together. What I will share with you today reflects the thinking, dedication and drive of an informal network of researchers, practitioners and experts coordinated by ENN and co-led by ENN and LSHTM. The MAMI Special Interest Group was formed in 2010 following a 2-year ENN research project that identified critical gaps in policy, research and programming. Currently, it is an informal network of around 71 researchers, practitioners and experts committed to harmonise effort, collaborate, share and learn. So what is MAMI? MAMI focuses on small and nutritionally at-risk infants under 6 months of age. Mothers and infants come as a package. The well-being of an infant is intimately tied with that of his or her mother. Babies that are born small or who are nutritionally at risk, such as wasted, stunted, underweight, failing growth, are at increased risk of death, of later malnutrition, of poor development, and long-term health problems. And there are lots of them. We estimate that 8.5 million infants under 6 months of age are wasted in the world. And as I say, it is not just infants who are wasted that are at risk. Infants who are underweight, stunted and born small have increased risk of death, poor development and long-term poor outcomes. Helping small and nutritionally at-risk infants under 6 months to grow well is a critical part of the life cycle approach. Making sure mothers are nourished and healthy before, during and beyond pregnancy is essential to safeguarding all children. Our reviews and research and capture of experiences worldwide found that support in the first 6 months of life was a greatly neglected part of the life cycle approach. Small babies grow into small mothers who have small babies. We need to break this intergenerational cycle of malnutrition. We urgently need to fill the care gap that currently exists for infants up to 6 months of age. We need to act globally. Helping small and nutritionally at-risk infants under 6 months is critical to our achieving the Sustainable Development Goals. So how can we make this happen? Our vision is that every infant under 6 months at every community or health service contact is nutritionally assessed and appropriately supported to survive and thrive. We want to ensure a continuous pathway of care that identifies, assesses and supports infants who are small and nutritionally at risk. So what does our vision look like in practice? We have detailed an integrated pathway of care that works with and within the system and services and particular needs of mothers and infants. It consists of community screening, outpatient assessment and care, and referral to relevant community-based and inpatient services. Unlike community-based management of acute malnutrition or CMAM, there is not a specific program model to follow. What a pathway of care looks like depends very much on the context. The MAMI approach is about making stronger links with antenatal services to ensure a continuity of care between postnatal care and community follow-up, especially of babies who are born too small. For example, it is about making the most of opportunities when we have contact with mothers, such as during antenatal visits and immunization visits. It is about making the most of every health centre contact a mother and infant has in the first 6 months of life, when they are well, like in growth monitoring programs, and when they are sick and present to a health post or health centre. The MAMI approach links prevention and treatment. If you take a public health lens, primary prevention prevents disease. Secondary prevention deals with early problems to prevent decline to something more serious, while tertiary interventions prevent serious negative impact on health. The MAMI approach straddles primary and tertiary prevention. On the nutrition front, it dovetails with infant and young child feeding interventions that operate more at the primary level of intervention. So really, MAMI is all about prevention. The MAMI approach is also all about building the right relationships between health services, mental health services, social services, nutrition programs, and beyond. From an individual level, between mothers and infants, within families and within communities, to multiple services. The MAMI approach is all about building bridges between infants and mothers, families and societies, in the community, from community services and community health workers. It links anthropometric assessment and functional outcomes. It links nutrition with health and disability. It links national and international agendas and actors. And it bridges humanitarian and development contexts. So where have we got to over 10 years of working together as a MAMI special interest group in this area? We have seen good progress. Infants under 6 months are no longer a blind spot as they were back in 2008. We have seen significant shift in policy, with the WHO Wasting Treatment Guidance update in 2013 recommending community-based management of wasted infants under 6 months of age for the first time. MAMI programming is being implemented in small-scale NGO-led pilots in several countries, led by Save the Children and Goal, including in Ethiopia. Several NGOs have also undertaken operational research, again including here in Ethiopia, that has really helped inform programming, tool development, and pose further critical research questions. But we are not there yet. Scaled up care of at-risk infants under 6 months who need support needs to include community-based management of their small and at-risk infants. Community-based management revolutionised the treatment of wasting in children over 6 months, but inpatient care still dominates management of infants under 6 months. A review we recently completed of 71 national and international guidelines on wasting treatment found only 5 included community-based management for infants. Most, including Ethiopia, still rely all on inpatient care that is more costly for health systems and families and is often not the best place for the support of these infants. We learned that governments are demanding more robust evidence before they change policy. They very reasonably want to know what interventions work and how in different contexts. How are they integrated within existing systems and services? There may be complex underlying pathology. How do we manage these? What are the implications for cost and capacity? And is what we are proposing scalable and sustainable? The need to answer these critical questions is what has brought us to Ethiopia. I'll now hand over to Carlos to elaborate more on critical research that we are undertaking in Ethiopia to help address this critical evidence gap.
Thank you very much, Marie. What I'm going to present now is a brief introduction of very exciting work that is being currently undertaken in Ethiopia. This work is being taken forward by a really nice collaboration between 4 bodies. This is led by Juma University here in Ethiopia. Is partnering with the London School of Hygiene and Tropical Medicine in the UK. Goal with representation in Harar particularly in DEDER, and with the Emergency Nutrition Network. So we are undertaking a community RCT in Ethiopia. This is called the Community Management of At-Risk Mothers and Infants Under the Age of 6 months, or the CMAMI RCT, or Cluster RCT. And this study has various components, and I'm going to be talking to you about these components. The first one, it has a secondary data analysis of existing data. Here we're presenting to you the DHS analysis that has been undertaken. It also comprises a health sector assessment, primarily to assess the possibility of inclusion of different health centers in the regions of Jima and DEDER for the RCT. It has the component of a qualitative study. It has the component of a health center survey, where we are trying to assess anthropometric deficit prevalence. And finally, the main piece, which is the cluster randomized control study. The community RCT has as a primary question, this is our main interest, we want to be able to answer at the end of this project is, does outpatient care using the MAMI care pathway that Marie has been describing will improve the growth of at-risk infants under 6 months. So this study, we are focusing on 2 areas. Here you can see a map of Ethiopia with all the areas nicely hinted. So we are working in all the areas of Jima zone. We are going to be selecting randomly health centers there for the RCT. And we are, you can see it here in the Oromia region, is on the west side. And on the east side of the same region, we have DEDER Warada, where GOAL has presence, and we will be also assessing the impact of the MAMI care pathway. Briefly, talking on the components, we have undertaken, and this was at the London School of Hygiene, a secondary data analysis of Ethiopia Demographic Health Surveys, or the DHS. What we were trying to ascertain in these surveys was first to try to map development of the prevalence of anthropometric deficit in infants under the age of 6 months. Here in this graph, what you can see is the prevalence estimates of the last 4 DHS surveys undertaken in Ethiopia in 2000, 2005, 2011, and 2016. And as you can see, in comparison with the year 2000, there had been a reduction in the prevalence primarily of stunted and underweight, although the prevalence of wasted infants remained more or less similar. Here, these are all stunted, underweight, and wasted, which are less than 2 standard deviations. But if we focus in those who are severely stunted, or severely underweight, or severely wasted, what we see is a very similar pattern. We have seen a reduction of the prevalence of severely stunted and the severely wasted from the year 2000 to the year 2016. However, again, the severely wasted prevalence seems to be more or less similar, slightly lower, but again, if we were to look at the confidence intervals, there is so much overlap that suggests that this hasn't changed for the last, well, almost now 20 years. Interestingly, when you look at the overlap of these indicators, what we see from the DHS data, and here we are looking at all the different surveys, and apologies if this is a little bit difficult to read, but what we're finding is that first, what we notice is a pattern constant across all 4 surveys, where there is not much overlap at this very young age between wasted and stunted. The overlap remained always very small with regards to the overall prevalence, and at the same time, underweight seems to account for a large proportion of the wasted and stunted. So by just assessing underweight, we could select a large proportion of those who are wasted and or stunted. It would always include those who are wasted and stunted, but according to the surveys, there seems to be that a large proportion of either wasted or stunted children might not necessarily be identified by just using underweight indicator. So those were briefly the main findings that we had from the DHS assessment. So I'm moving now to the health center assessment that was undertaken in August, September. Now, one thing I want to point out that it has been very challenging, and our colleagues in Ethiopia had been fantastic at managing, is that data collection of all the components that I would be describing had been occur under COVID restrictions. So there had been a lot of difficulties and challenges along the way to be able to collect this data. So with that in mind, we undertook a health center assessment, I think was between August and September, where we managed to visit 71 centers, 63 of these in Jima, and all of the centers that exist in Dada. And we collected a lot of information that would allow us to rank the health centers according to a potential eligibility criteria, such as how far they are from each other, how easy they are to access, and how much patients are, especially, well, not patients, just infants under the age of 6 months that are attending these health centers, to be able to assess whether, how long will it take us to reach a minimum sample size, and whether there is sufficient patient load to select, to justify selection of this center. So among these findings that we had from this rapid assessment, first is that the health records that are kept inside suggest a very low patient load that is not necessarily been observed now that we are undertaking a health center survey. So it appears that the health records in these centers have lower, or suggest that they have a lower patient load than they actually have. They seem to have a lot greater load. But also this health center assessment has been helpful now to be able to allow us now to select health centers for the survey, to test the eligibility criteria that we are setting up based on those three elements that I discussed: distance, ease of access, and patient load for the RCT. This takes us very nicely to the health center survey, where we are now trying to collect data that help us understand how high the anthropometric failure is in infants under the age of 6 months in the two regions that we are interested in studying. So at present, we are undertaking that survey, so we're still collecting data. We are doing it at present only in Jima, and we are completing preparations for undertaking it in Deda. We're hoping that we will finish it in Jima by November the 27th. So we have collected data already of 590 infants under the age of 6 months. We have only processed or cleaned, so to speak, in a data set 510 infants. So I'm going to be presenting you a very brief preliminary analysis of those 510. So the first thing that we'll show you here is how anthropometric failure looks in this sample. So first, what we see is that of the sample of infants, of the 510, about 430 does not present any anthropometric failure. That is about almost 85%, or well, let's call it 84% of the sample does not have any anthropometric failure, and almost 16% will present some form of anthropometric failure, whether this is being wasted, being stunted, or being underweight, or potential combinations of those. What you can see here also in this table, and this is a very useful table for assessing what is being termed a multiple anthropometric failure, is that the multiple anthropometric failure prevalence, for instance, like being wasted, stunted, and underweight, is not very high at this particular age group or in this particular region. So, well, this is just an interesting finding. Interestingly, if we do a similar assessment that was done with the DHS data, and we're trying to understand the overlap between the different indicators of anthropometric deficit, that is, whether you are stunted or short for your age, whether you are wasted or short for your length, or whether you are underweight, which you are light for your age, we see that of the total of stunted, wasted, or underweight children, we see that there is first and foremost not much overlap with stunted and wasting. This is congruent with what we saw in the DHS surveys. Now, contrary to what we found in the DHS surveys, in this particular clinic survey, we found that underweight as an indicator does capture most of the children who are stunted and most of the children who are wasted. So there is a very, well, it's not very small, but it's still a small proportion of all the wasted children or of all the stunted children who would not be underweight. So that increases for us the confidence that if we were, for instance, to roll out a MAMI care pathway focusing on identifying children who might be underweight, it might increase our chances to capture all the different types of anthropometric deficit. Also within the survey, we have been collecting data on feeding practices. So here I'm giving you a very quick overview of the prevalence or the presence of exclusive breastfeeding in the first 6 months of life. So what you're seeing in the graph here, you're seeing a proportion. So again, the value of 1 talks about 100%, the value of 0 is 0%. And I am presenting you here how the exclusive breastfeeding presence disappears with age. And what we see is that in the first month of life, we are never above, at least by data from the survey, above the 80% of infants are exclusively breastfed. So you have a 20% of which liquids had been already introduced at this very early age. What we are seeing is that by the age of 8.6 weeks, at least half of the children at this by 8.6 weeks, half of them will not longer be exclusively breastfed. And you can see how quickly this exclusive breastfeeding disappears. Now, it is important to try to contrast this with the recommendation that all children should be exclusively breastfed up to the age of 6 months, or for instance, in this case, up to the age of 26 weeks. So any area above the line that you are seeing in these figures are all the children who should have been exclusively breastfed who are not exclusively breastfed. So this points to us a very important area through which the MAMI care pathway could try to address that is likely to impact on the well-being and development of these infants. The qualitative study is one of the last components before we start before we undertake the cluster randomized control trial. The qualitative study has very specific objectives, primarily try to understand the perceptions of mothers and families about the well-being of infants, about feeding practices, about malnutrition in this particular age group, to understand also how to best support these vulnerable infants and their carers. Now, I won't be presenting to you any of the headline findings of this study, primarily because there are too many. Our colleagues in JIMA have done a very exhaustive study, and at present they are trying to really summarize the wealth of information that emerged from this study. I just wanted to mention that we undertook 31 in-depth key informants interview, and briefly tell you that of those 31 infants interview, we interview many mothers, so we are trying to get very good information of the usual primary caregivers, but also of fathers, members of the health systems, and members from kind of more decision-making people or personnel at the on the health system. So we managed to collect a total of 31 interviews, 21 in GIMA and 10 in DEDER, as expected. And as I say, there is so many very interesting information that is emerging from this study that will be fed into the community and the cluster RCT. So I have just given you a very, very brief prime of all the different components of that are going to be part of this project, that we are trying to use all those findings to feed into the development of a cluster randomized controlled trial, where we're going to be testing the MAMI care pathway. And our main or our primary objective will be to try to see what the implementation of the MAMI care pathway, with a very strong focus on outpatient care, but also more community activities. How did that impact the growth of at-risk infants under 6? Now, obviously, at the moment, we are still in development. So we're still working to develop the protocol. We are hoping to submit to ethics by the end of this month. So this is still an ongoing process. But what we want to focus is testing this care pathway on the growth of infants, but also on the mental well-being of primary caregivers. And we really want to try to assess the cost effectiveness of this approach. We believe that this is likely to be very cost effective, but we want to assess that. This we will try to implement it in 36, or we are aiming to implement it in 36 health centers. This will be randomly selected within those who had been eligible to participate. We're going to select 28 at random in GIMA, and we're going to have an exhaustive sample in DEDER. We're going to include all of them in DEDER. And we are expecting in this study that we will be following at least 2,700 infants under the age of 6, this ranging from the ages of birth all the way to under 6 months. And hopefully we will be able to follow this sample for about 24 months and assess how care from this very early period is likely to impact in the first 2 years of development. And I think that's all for me. Thank you very much.
Thank you, Carlos. As a global effort, we are now stepping up on what we do on MAMI. We are scaling up our MAMI special interest group into a MAMI global network. As reflected in what Carlos has shared, we want to co-create and co-deliver robust, relevant research that is driven by country agendas that informs national and global policy development. We want to do even more together to galvanise and support collective, collaborative, harmonised efforts on research and policy to inform best practice that is scalable and sustainable. We have been part of a MAMI evolution over the last 10 years. We want to bring about a MAMI revolution. This is why we have turned to Ethiopia. Ethiopia is special. Ethiopia is a nutrition champion. Other countries and global actors look to you for leadership and are influenced by you. From ENN's perspective, we've got a great example of collaboration in a conference we collaborated on with the government of Ethiopia, capturing government experiences of CMAM scale-up that brought 16 countries together to share learning in 2011. an event that proved hugely influential internationally. As a MAMI Global Network, we want to work together with regional and national networks, groups and leaders, just like the Ethiopian Nutrition Leaders Network. Thank you so much for listening and for this wonderful opportunity to connect with you and explore how we can practically connect and work together. A final word of thanks to Irish Aid for sustaining ENN in our MAMI work for many, many years, and to the Eleanor Crook Foundation, who are funding the critical research in Ethiopia and are supporting us to scale up into a MAMI global network. Thank you.